I would like to begin today's session by acknowledging that Physiotherapy Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. Physiotherapy Alberta recognizes that Indigenous peoples have been helping many live healthy lives on this land long before settlers arrived. And with that, we commit ourselves to helping move people forward in their journey towards a good life, and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today, and we encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. My name is Leanne Larange, and I'm speaking to you from Edmonton, and it's my great pleasure to introduce Christy Harcourt. Christy Harcourt is a social worker, educator, and consultant focused on the well-being of LGBTQ people. She teaches about gender and sexual diversity at MacEwan University and is a clinical social work practice in Edmonton. And she's here this morning to speak to us about LGBTQ affirming care in physiotherapy practice. So I will turn the floor over to you, Christy.
Wonderful. I want to thank all those people who let Leanne know that we were indeed being heard. That is very reassuring. Welcome, and it's so good to have you here. This is a new platform for me, and so I really appreciate Leanne and Sean's help in learning it. It actually was hard for me to compute that I wouldn't be visible to you. For some reason, I thought I would be on camera, so I haven't put a picture of myself, but I am a white, fat, cisgender woman. I'm a queer person, and I am really committed to improving service outcomes for LGBTQ people, and I think that one of the ways that we can do that is by working on the provider side. I have worked for a number of years around healthcare access for LGBTQ people, most recently with the LGBTQ Wellness Center in Edmonton, but previously with the Pride Center of Edmonton and with the Boyle-Macaulay Health Center. What we're going to do during this hour together is talk a little bit about some terminology and some approaches, some things that we can do in our treatment relationships with clients to have positive working relationships and to reduce some of the barriers that can come from social oppression that impacts LGBTQ people. We're also going to talk a little bit about some things that might happen outside of the treatment room that could have implications that can undermine our good work, honestly, in our larger clinics and larger systems that we can pay attention to and advocate for change around. And I'll ask a couple of poll questions, and I would really be grateful for your responses to those. And then at the end, we'll have some time for questions and answers. As Leanne mentioned, we've shared a number of resources that I hope will be a good fit for you that are really focused on either healthcare or physiotherapy-specific environments that can give you some opportunity for further training and further reading. So when I was planning for this conversation, I was thinking about, what might be some of the times when a physiotherapist might work with an LGBTQ patient or client, with someone who is gay, lesbian, bisexual, transgender, queer, just what some of those letters mean for me. And I thought just about the whole realm of the work that you do, that you might be working with people around a sports injury or other injury, around increasing or maintaining mobility across the lifespan. You might be thinking about working with somebody in post-surgical recovery, in pelvic floor health, or in many of the other dynamic ways that you work with your patients or clients. One thing that I was thinking about, and I'll try to sort of share some little bits of information that might be useful to think about as we go through. the tricky thing when you're talking about a wide range of the population is to think about how do I share some specific things without overgeneralizing. So one thing that I will say when we think about working with people across the lifespan is that while many LGBTQ people may have children, it is less likely that LGBTQ people will have children than their counterparts who are not. And so one of the things that can mean is that it may be less likely that people have intergenerational supports, either the access of older people who can help them get to appointments or younger people who can help them to get to appointments or follow through with treatment. And so that's a thing to think about. So if you thought about as a visual, a long horizontal line, you might find that it is more common that gay or transgender people that you work with, that most of their social networks are in a similar age band as they are. So one of the challenges with that is that people might be aging at the same rate as their counterparts, as their partners and friends, and that can make it harder to get some supports from older people when we need help from older people, or younger people when we need help from younger people. So that's just a dynamic that's important to be aware of. When we're thinking about working with LGBTQ people, there are sort of parts of the person that are important to think about. And so I've got two different kind of sets of information on this slide. One is to think about, so we want to think about people in terms of their sexual orientation, which might be being lesbian, gay, bisexual, two-spirit, queer, heterosexual, or other terms. You might think, if you want to think about where do we locate these things in the body, you might think about sexual orientation, your romantic or attractions around in the heart. We might think about gender identity, your sense of yourself as a gendered person, your sense of yourself as a woman or a man, as neither, as transgender, non-binary, cisgender. You might think of that as occurring in the brain where you have that awareness. Gender expression we might think of as being on the outside of the body. The gender expression is how we adorn ourselves, how we present ourselves in a very gendered world, as masculine, feminine, as androgynous, or other ways. And then one more that's in the illustration is we might think about sort of sex assigned at birth. And so sex assigned at birth is what was determined for us at birth based on the appearance of our bodies, based on our genital appearance. And so those are all parts of us, parts that all of us have, and that we have different relationships with. One other piece of terminology that I've put here, and this is obviously not an exhaustive list, is misgendering. So misgendering is a term to describe when someone refers to another person by the wrong gender or the wrong pronoun, whether they do that intentionally or unintentionally. And that's an important concept to understand as we're thinking about this. So we're going to do a couple of really quick poll questions. First of all, I'd like to know, so we're going to kind of separate out sexual orientation from gender identity. First, I'd like to ask if you could please rate your knowledge and familiarity with different sexual orientations. You can just click one of those and then submit. And Leanne, I'm not sure how to know how much time to give for that, but if you have any advice for me, I would be happy to accept it.
Give us 2 seconds, Kristy.
Yeah, perfect.
10 or 15. I'm watching on another screen, and the poll launched quickly for me, but I know that's not always the case.
Oh, yeah. Okay. So, yeah, so if you just would think about whether you'd call yourself, like, on the more knowledgeable side, on the somewhat knowledgeable side, or on the less knowledgeable side. And these are anonymous and meant just to give us a sense of the knowledge level in the room. Okay, I'm going to click to poll results, see what we have. Okay, so we thank you so much for doing that. I really appreciate it. So we have fairly even groups in the very knowledgeable piece and in the little knowledge piece, and the majority of us here in the room know ourselves to be somewhat knowledgeable about different sexual orientations. You're doing great. Okay, so here is the next poll. If you would do the same thing again, how would you rate your knowledge and familiarity with different gender identities? And again, if you would indicate whether you are very knowledgeable, somewhat knowledgeable, or have little knowledge. Okay, and we'll just give another minute. This one was a little bit slower. And thank you so much for responding. Well, this one's very, very similar. So people, a fairly similar number of people were very knowledgeable. Again, the cluster, more than half, were somewhat knowledgeable, and then a slightly larger group had little knowledge. So I'd say that you are in really good company with the rest of the world in terms of having a bit more knowledge about different sexual orientations, a little bit less knowledge about different gender identities. Thank you so much for doing that with me. I really appreciate it. So when we think about sort of gendered categories, something that I think can be really helpful is to think about what our norms are. And so if your norms are very binary in terms of gender, and we'll talk a little bit about how those might show up in a moment, it can be helpful to think about just sort of expanding gender categories. So if the way that you think about gender is very much, there are two, one of them is man and one of them is woman, it can be helpful to think, okay, that was an incomplete set of knowledge that I had. There's more than that. And it can be helpful to think that there might be sort of a third set of categories that are for people who don't fit into those gender categories, don't fit into them all the time, or are outside of those gender categories. And we'll talk a little bit about how people might understand that. But I think that that's sort of a basic thing that we want people to be thinking about as they're thinking about how do I provide affirmative care is, are the categories that I have sufficient, or are there more categories than that? So key to understanding and working with a new population or enhancing our work with a population is really having a sense of what our internal norms are, what our internal bias is. And so this is a thing that I will really invite you to do some thinking about now and later, to think about what are some of the things that are really normal for you. And so we might think about gendered greetings. I have been as a guest speaker in organizations where I'll be in a group. The group appears to me to be a mixed group, and so the person starting the meeting will say, "Good morning, ladies. It's great to have you all here." Looking around the room, I am quite certain that I am not the only person in the room who's not a lady. I am no kind of lady. And so those are interesting moments, aren't they? When somebody will, and when I've asked people about that, they'll say, "Oh, well, we used to all be ladies, but then we hired this guy," or, well, majority. And so sometimes we have these norms that feel really comfortable for us, but may actually be rubbing up against the reality of the world around us. So think about how gendered greetings, guys, ladies, how those kinds of things operate for you. What are your norms in terms of correspondence? And so are you used to writing Mr. or Ms. as ways of identifying people? What are your norms about how gendered bodies are supposed to be? Do you have ideas about ideal body size or composition that even if you to sort of challenge those for yourself. I was having a conversation with my partner last night, and she said my colleague talked about that they thought I'd lost weight again, and I don't engage in those conversations, and I've run out of polite ways of saying, please stop talking about my weight. So think about what your gendered norms are about that. And then also think about the gendered norms that your space dictates. So are there gendered spaces on site where you work or where you socialize or where you pray or where you interact? Change rooms, washrooms, or resources. So I think, for example, about if you go for, I joined the mammogram club this year. It's really fun, as it always is. And I was given this short pink robe, and I thought, oh, pink. Okay, that's interesting that that's a code that's sort of built in. So think about how pink or blue might be used or other kind of colored coding. And then I also want you to think about what are the gendered norms that are portrayed in the visuals in your space, particularly in your workspace. What are the images? What kinds of genders or gender expressions are shown in posters, in art, on your website? How is gender represented in your practice or in the places where you represent yourself? And so that's a little bit of a thing for you to sort of look at as after this session. It's also really important to understand intersectional impact. So intersectional is a way of understanding when several characteristics layer upon each other and can have different impacts. And so what we might think about as the barriers that a white abled person who speaks English experiences, and then how other factors can layer upon that to enhance service barriers or create more confusion or difficulty in accessing service. And the reason I have this image of keys here is there's a really good example that Dr. Danielle Pierce in the U of A uses, and I'll describe it to you. So basically, when we think about intersectionality, as it says here, when people experience additional layers of social stigma or exclusion, such as racism, anti-fat bias, it can be that much harder to find suitable care. And this can impact our work as service providers, as well as our work in referring or receiving referrals. So Dr. Danielle Pierce uses this great key example. And so what they describe is, if you imagine that we have a person who is, for example, gay and also disabled. If we think about the part of them that is their identity as a person who is gay is the little yellow key that we see here, and their identity as a person who is disabled is the little blue key that we see here. They carry those identities at the same time. They're not discernible. You can't just be gay but not disabled here and disabled but not gay there. And so in reality, that person is a combination. They're a green key. And the problem with the green key is that it may not actually work in the yellow lock or the blue lock. So when we have multiple identities that experience social stigma or exclusion, it can cut us off from both of those available spaces. In the case of a person who is gay and disabled, we might have a situation where the disability community that they try to access might be really homophobic, and that the gay community that they try to access might be really inaccessible or really ableist. So that's an important thing to think about. I will tell you that one of the things that I noticed immediately when I started working with patients who were LGBTQ was the referrals I would receive would be really weird. So that's a thing you might just tweak right away, that the other people's writing would come in, and I would literally get referrals that said, John is a healthy 40-year-old man who says he's a lady. That is a practitioner who has not asked enough questions and who needs some training. Because in that situation, I didn't know what name they use. I knew very little about their identity, and I really had to sort of do a lot of extra work that the original practitioner might have done. One thing that is really important as a marker of interest in working with transgender people particularly is comfort with pronouns. Pronouns are the way that we are referred to in the third person, and so I've listed 4 kinds of pronouns here: he, him, she, her, they, them, and then there are some other purpose-created pronouns such as ze-zer that people might use. Pronouns are the doorway. They're the bottom skill that we can demonstrate. And so that's a matter of like being able to pronounce somebody's name. And they're really important. Of course, they, them, some people kind of get caught up in whether that's a plural or a singular. Unless you are the head librarian of Canada, it's not your job to be the grammar police. It's your job to affirmatively treat your client. And so I will tell you that you probably use they, them all the time. If somebody double parks your car, you want them found, you want their car moved. So we use they, them in the singular all the time when we don't know the gender of the person we're referring to. So how do you talk about pronouns? Well, I talk about pronouns with every client. For me, it's a good practice. I don't only do it when I'm not sure, and I always start with myself. So in this illustration, we have someone who says, "Hi, I'm Robert. I use he or they pronouns. Hi, Robert. I'm Anita. I use she, her pronouns." Our pronouns could be communicated verbally, on signage, on business cards, name tags, websites, and sign-ons. So like when I sign into Zoom. Once we have communicated them or asked for them, it is our job to remember and use them. So, and I'll talk a little bit later about how we can set up our systems to support us in that. One of the things that I know can be very frustrating for people is when they have been asked, they have communicated, they've taken a chance on us, and then we don't follow through. So that's an important piece. I've used a couple of slides here that are from another project because I really like the graphics on them, and I'll talk a little bit about this project afterwards, which is called the Trans Wellness Initiative. So as I said, pronouns, they matter and they need attention. Something that's really important to know is that there can be flux in identity sometimes as people are getting comfortable with themselves and comfortable with us. So someone might introduce one pronoun, say that they could use he, him, or that pronouns don't matter to them. And then as they get to know us and trust us more, they might give us more information about what pronouns they use. And please don't treat that as a pain in the butt. Please treat that as an investment in you. You are doing something right if your client or your patient tells you something truthful about their life. That's a great sign that you've got a good therapeutic relationship developing. So that's a really important piece. I've put some little suggested scripts here to help people to think about when they might use pronouns. And so I'll give a couple of examples here. Explaining how you're going to use the information. So for example, I see that you use he and they pronouns. For the written referral I'm making to you to another professional, what would you like me to indicate? Is the name that you've given here the name you'd like to be used in the clinic? So just to really give people a sense of that they have some control over their confidentiality, privacy, and how they're going to be referred to. Something that can be, sorry, I'm going to wait 1 second here, there. Okay, so then I have a couple of thoughts about in the treatment relationship or in the treatment room. Again, without generalizing, I will say that it is common, there are many people in the LGBTQ community, particularly trans and non-binary people, that might have conflicted relationships with some of the gendered characteristics of their bodies or the characteristics of their bodies that are read as gendered by other people. That can include being deeply sensitive to attention to gendered features or body parts, having different ways of referring to gendered body parts, such as chest instead of breast, or seeking or preferring features that may otherwise be socially stigmatized, such as body hair, the fat distribution, body size, that read in a way that are more preferably gendered. So, for example, I have worked with clients who have said, like, it was a real relief to me to gain weight because people read me more as a guy. Or I try to keep my weight really low, and sometimes I have concern about people's health as they do that, I'll tell you, because it reduced my body fat, and that meant my breasts seemed smaller and people didn't notice them as much. So knowing that people might have particular ways that they try to deal with their feelings about gendered characteristics in their body. Also, it's really important to know that many LGBTQ people, and particularly trans and non-binary people, might use gender-affirming garments and practices, including chest binding, that could have an impact on their ability to move, their freedom of movement. And it's really important that practitioners value what the client values, even as we're working with them on really healthy approaches. So I've worked with many clients who bind their chests. It's really important that people use proper chest binders. It's really important that we help people to figure out where to get those, and I'm happy to answer questions about that. And then if we're doing, specifically if we're doing something that involves physical movement, that we think about what's the safest way for you to do this movement if you do bind your chest. So that, I'd say that that's something for physios to really pay attention to. You've probably heard about the idea of fight or flight, but I want to sort of expand your idea about that. And I know this might be something really familiar to some of you. This might feel off topic to others of you. Yes, I work as a therapist, and I really think about the brain. But so when we think about fight or flight, there's actually four that we want to think about. We want to think about fight, flight, freeze, and fawn. These are reactions that people have when they face a threat. And so I want to mention that we might see some of these traits in the treatment room. Fight or flight might show up as a sense of inflexibility, that there's only one way to do something. Flight might show up in changing topics or avoidance. Freeze might show up as silence, somebody not hearing or talking when we're talking to them. And fawn might show up in surface level openness or surface level agreement. So when people seem to get it but then don't follow through, that could be a lot of things, but it might be a fawn response. And because in our practices these things are often characterized as noncompliance or defiance, I think it's really important to understand that those can also be responses to a feeling of threat. This can also be true in us. Sometimes when we are uncomfortable, we get inflexible. When we are uncomfortable, we give surface level openness when we're not really planning to change. Sometimes when we're uncomfortable, we change the topic or we silence things. And that's something that I've really seen in my clients in some of their therapeutic relationships. I've had many clients who have been fired by their doctor when they came out, particularly as transgender, where they asked for particular care and they were just given delay after delay after delay rather than their doctor checking out how they could get that treatment. So these trauma responses or threat responses can show up in our patients in certain ways, but they might also show up in us and our colleagues in really specific ways. Some other treatment planning considerations. For LGBTQ people, the experience of medical trauma is widespread. This can lead to avoiding medical care, postponing treatment, and people showing activation or distress in situations where another person might be calm. And so I think this is an important thing for us to have an awareness of. I found that my intakes took longer, particularly where there was medical trauma, because I had to sort of help my client to co-regulate or to sort of get calmed down enough to go ahead and do intake information. Also, when we think about being trauma-informed or trauma-sensitive, one thing we can think about is if we do ask invasive questions, if we do ACE or Adverse Childhood Experiences scoring, anything like that, that should happen not on the same day, if possible, as any kind of physical touch treatment. That if someone has a trauma experience, separating out hard stories in one's past from physical touch situations could be a really important separation for them to have success in being able to access the treatment. Also, if we are referring people to exercise facilities and other gathering spaces to do exercises that are prescribed in physio or advised by physios, it's really important to know that these can be some of the most unsafe places for people who don't live their gender in a really traditional way. They can be sites of trauma rather than sites of inspiration or calm for some of our clients. So it's an important factor to think about. Okay, so some team, clinic, and environment factors. And what I really want you to think about why this matters to you. I know you may not be able to change your whole clinic environment, but if you're going to do this work of being an affirming provider, I don't want you to be let down by your clinic environment. And these might be reasons why you might need to advocate for change in your clinic environment. So I want you to just really put on your gender goggles and look for gendered factors in your environment. We already talked about the signage, the visuals in the space, the pink and blue coding, that kind of thing. But also I want you to think about names. What names are used? Is legal name required? Can it be buried a little bit? Can we have name used? How do we showcase the name used? And I'll give you some ideas about that. How do we share our pronouns so other people know they're allowed to share theirs? What titles do we use? If it's common for people to be called or called for as Mr. Morrison, what options do people have? I will tell you that when I register for a conference, if the only titles offered on the registration are gendered, I pick the really outlandish ones. So if I'm only offered Mr. or Ms. or Mrs., and then down the list it'll say Reverend, Doctor, Professor, Lieutenant, I always choose Lieutenant. Senator, I'll choose any of those because we need to have non-gendered options. And a good one is Mix, MX, which is something that people sometimes use as a non-gendered title. People's emergency contact might not be their next of kin, and so asking people, who do you actually want me to call, who can I share information with, is very important. And then it's really important to find out if you use a contact management software, whether your software contains gendered categories that limit what services can be offered. So, for example, when I worked at the LGBTQ Wellness Center in Edmonton, we found out that if somebody was coded as male, we could not set up a reminder in the system for gynecological care annual checks like PAPs. There was something in the system that limited that. So once you code somebody by gender, is there a consequence in what you can provide to them in that system? In order to improve service outcomes, it's really important to involve all or as many clinic and staff team members in awareness, including the reception staff, most importantly the reception staff, to consider client confidentiality in the waiting room, in files, referrals, and reporting, to address awkwardness or remarks regardless of whether you think clients hear them. You might be surprised. And I'm not a big believer in the safe space sticker, particularly because I have heard stories about people using the safe space sticker mockingly, as if it's like the Staples easy button. So somebody makes a homophobic joke and then high fives the safe space sticker to say like it's a do-over or something like that. So I think that they are sometimes aspirational, but they are of limited utility if you're not actually going to be following them up with other actions. So this is a software piece. This might be just a slide that you hand to your IT person, but I want to talk about that. So first of all, it is possible to change your name and gender marker in Alberta legally, but there are so many challenges to do that. There can be financial, legal, and personal factors that prevent these changes. There can also be so it could be that your legal name, you can't change it because your immigration, it'll affect your passport when you have dual citizenship, or you're waiting for citizenship to come through. There can be just lots of factors. So legal names differing from chosen names should not impede us from providing affirming care. Software systems are the worst. They do not anticipate trans and non-binary people. And so there are some software workarounds we can use to help us provide patients with a safe environment. One is, so my example here, a patient is a trans feminine person. She uses the name Sarah, though her legal name is David. So what we would do is, in the alias or preferred name categories, we would highlight what is used. So we would put Sarah there. We would make chosen names highly visible by adding them to the legal name field. The clinic where I worked, we did this with every patient, even if their name was only one name. So it would say David, and then it would say in brackets Sarah. If Sarah hadn't ever changed her name, it would say David in brackets David. So we know that that's the only name. And then if the software has a global message pop-up field, you can use that to queue names and pronouns. In this case, when you click on the patient's appointment, a pop-up global message will say, uses the name Sarah, pronouns she, her. You could also use that for other things that are really important reminders on the day of appointment, such as if your patient is a wheelchair user and you don't have a lot of wheelchair users in your space, it can be a good place to put that, where you can have the reminder to just check that there's a clear path for your patient on that day. So I would say do these tweaks for all patients so that it becomes the standard practice of your organization. Okay, I'd like to share a case example here, and I'll read it out. This case example comes from one of the resources that we're providing today, the Introduction to LGBTQ+ Competency Handbook for Physical Therapy. A 22-year-old woman enters the clinic as a first-time patient. She tells the receptionist she's never been to physical therapy. She's given an intake form to fill out, on which she reports that her gender identity is female and her sex assigned at birth was male. Her first name is Markeisha, but her identification, or her legal name, lists a masculine first name, Mark. While she's waiting to see her physiotherapist, she enters the women's restroom. After a patient comes out of the women's another patient comes out of the women's restroom and reports to the receptionist that she thinks a man is in the women's restroom. The receptionist sends a therapy aide into the women's restroom to see if there's a problem. Therapy aide returns and says everything is fine. Markeisha exits the restroom and sits in the waiting area. A physiotherapist appears with a chart and calls for Mark. Markeisha looks around sheepishly. The physio again calls for Mark. The patient who had reported a man in the restroom laughs. Markeisha gets up and goes up to the physiotherapist, who takes her to an exam room. So there are a few things that have happened in this situation. One is Markeisha has just brought herself to physiotherapy in a space that is gendered. It's not Markeisha's fault that that space is gendered. It's the clinic's decision to have gendered spaces. So that's a piece that's happened that's without her control. Something that went well is that when somebody had a question about the washroom, somebody checked, didn't hassle Markeisha, reported that there was no problem. Something that could have helped in this situation would be for the name used to be clearly identified in all of the services, so that Markeisha is called for appropriately and not caused embarrassment or discomfort or potentially unsafety in the waiting room. And the other thing that I would hope would happen is that the patient who has been rude to another patient would be reminded of the conduct expectations of patients in our practice. So this is just one example. There are other examples that are provided in the handout resource. I feel like I was worried about time, so I rushed through. I'll take a second here. So this is sort of one of the closing thoughts as before we go to Q&A. And so if you have questions that you're mulling over, I'll invite you to start thinking about them and putting them in the Q&A so we can address them. I don't know what other people's stereotypes are about LGBTQ people, my stereotypes about LGBTQ people are of tremendous strength and resilience and survival. And so one thing that I have learned is that my patients and clients come with their own communities and connections and resources. They have overcome, they have survived and found new ways of working. They have adapted to family members who sometimes have been very difficult, and they have found new connections and loves and supports to help them to thrive. So a question I always ask my clients is, how have you overcome in the past? How did you survive? How did you get here? I think it's very important that we, as healthcare providers, affirm their ways of managing and maneuvering through barriers and systems, because they might have clever, creative, amazing ways of doing that that we would never have thought of, that would just be really outside of our radar. So this is an important thing, I think, to ask of all of our clients, but it's something that I particularly ask of LGBTQ clients. And then I wanted to talk a little bit about some of the further resources that Leanne has made available to you. The first one that I've listed here is the Trans Wellness Initiative's free online training, which is for Alberta health professionals. If you take the entire training, it can take about 5 hours, but it's all blocked down into about 20-minute videos and discussions. It features a wide variety of providers from different health professions, and it is totally free. So it's something that you could set as one of your New Year goals to complete the Trans Wellness Initiative training over the course of the year. You get a certificate at the end that you can count towards your professional development hours. There are a couple of articles about physiotherapy with LGBTQ individuals. One of them is specifically about working with transgender individuals, and the other is specifically about pelvic health physiotherapy. Then there is some really interesting research about trans and non-binary people's experiences with healthcare in Canada through TransPulse. And then finally, there is the LGBTQ+ Competency Handbook for Physical Therapy, which that case example came from. And it's a very thorough, excellent, I think it's about a 30-page handbook with a lot of different case examples that you could take into a staff meeting and just discuss with your team. So I don't have a slide that says Q&A. So maybe what I'll do is scroll back to, this one, which has my email on it, and then you can reach me if you want to with any questions. So we have a little bit of extra time for Q&A, and I would just love to know, a question I have is, that I'm always interested in, is, was there something here that gives you something useful to start with? Could you start with examining your own space, with addressing, the awareness in your clinic, just to get a sense of what could be useful? So that's a question that I have for you, but it'd be great to know what questions you have.
Sorry.
Hi there, go ahead.
And I'm not entirely sure I'm understanding the question, but I'll read it to you and tell you what I think I'm translating it to mean. So from Cody, she asks, is there an equivalent Trans Wellness Initiative training that individuals from other conferences can complete as well, or would it be okay for us to complete too? And I'm assuming she actually means like other. Is
a conference a region?
I assume that's what she's meaning.
Oh, yeah. You can do it from anywhere, Cody. It should be available to you from anywhere. It is based on the Alberta healthcare system, and so there might be some slight limitations to that. But other than that, as far as I know, you can take that. There's also Rainbow Health Ontario has had some trainings in the past, and I believe they're free of charge if you're located in Ontario, or at least one of them is. There's also some training that's available through a couple of different organizations. One is called WPATH, WPATH, or CPATH, CPATH, which are the associations of physicians and nurses focused on transgender health. So those are some great resources that one could access.
And I have a comment from Karen who says, I've been wondering how to make our department more experimenting with asking patients which pronouns they prefer, and this presentation has helped me have the confidence to make some changes that I've been planning. So thank you for that. And I have a question for you about language from Karen's question. And it has to do with how you refer to or how you ask someone their pronouns. And I'm wondering if you can comment on that in the best way. I know you said, you start with yourself, but are there any other tips, tricks, or pitfalls that maybe people should be aware of when they're having?
Absolutely. So I'll put this slide back up. So one thing that I would make note of is people's pronouns are their pronouns. They're not preferred. In the same way that their name is not preferred, my name is just my name. And so I just use name used, pronouns used. I think a really good practice is to be consistent with all people. And if you ask somebody what are your pronouns, sometimes you'll get people who don't understand what pronouns are. And so just to say, if I referred to you, I want to make sure I refer to you appropriately. So if you were to leave the room, I want to make sure that I refer to you appropriately. So I always start with me because I think only asking somebody their pronouns suggests I am a picture of clarity, but you're confusing. So I always start with me. I also think it's really important to know that pronouns are culturally and language specific. So we have gendered pronouns in English, French, Spanish. There are no gendered pronouns in any of Alberta's predominant Indigenous languages, in Cree and Dene and Blackfoot. I have been told, although I do not understand these languages, that there are no gendered pronouns in Tagalog or Mandarin. So there might be situations where people get pronouns confused or get a bit muddled around them, particularly if they don't come from gendered pronoun using languages. So in those other language contexts, typically people would have the equivalent of like me, you, and that other person, but they might not have a gendered term for that other person.
Well, that's fascinating. I never knew that. Thanks. That's a great tip.
Yeah.
Yeah. Okay, Caitlin had a comment that she wanted to share. She says, I appreciate your comment about clients taking time to disclose their pronouns and framing that as letting you in or building the therapeutic alliance rather than an inconvenience. Thanks for the great.
Oh, wonderful. Thanks for that, Caitlin. I really appreciate it. And I do find that people often act like clients giving us more information is a hassle. And thank you for that, because it reminded me of something I'd wanted to say. I have noticed among my students sometimes that they will do this really weird thing, and I wonder if you've ever heard somebody do this. Ironically, at a moment when they're trying to convey their affirmation and support, they say the least supportive thing, which is, I don't care. The way they say that is they say, I don't care if somebody's gay. I don't care if they're trans. And they say it in the moment when they're trying to say, I care. I want to be an ally. So saying I don't care has the opposite impact of what you think it does. And so I think it's really important to say that, if you want to say, I thank you for telling me. A better thing to say if somebody tells you that they are gay or transgender is to say, oh, thanks for telling me. I really appreciate that. If there are any considerations that are important for me to take into account, please let me know. Or if I screw this up, please let me know. Also, if somebody tells us some information and we do screw it up, we forget about pronouns, we misgender them, the most important thing to do is put down the shovel and keep going. So apologize. Don't dig yourself deeper. Don't make this more of a problem for them. Sometimes we make a mistake and then we just make the person regret they ever said anything about it because we go on and on about how bad we feel. Not the time for it. If you misgender somebody, you say, I'm so sorry. I'm making a note of that. I'm going to work really hard on that, and you just keep going.
Sean and I are discussing in the chat, and we both feel that we've probably been guilty of that I don't care statement, and that is such a powerful point to make. Thank you for that. Chris,
you're welcome.
That is Yes, so true, so true. Krista is asking, would it be acceptable to always use they in documentation? So, for example, a discharge summary is a standard. She says she recently had an LGBT student who strongly felt that this should be done. And beyond sort of the regulatory aspect of it, I'm going to ask you a slightly different variation on that, which is, should they just be our default until someone tells us one way or the other absolutely?
No, my default is to ask people. And the reason for that is that there are people who really had to fight to get she. And if you were called the wrong pronoun your whole life, and you had the bravery to let people know that they should refer to you as she, her, that person has the right to be called she, her, and we should honor their desire to be called that. Trans people experience that often when people are happy with them, they use their pronouns appropriately, and when we're mad at them, we misgender them. So there's a conscious or unconscious weaponizing of how we use pronouns. This is a thing that teenagers report to me all the time. When my mom is mad, I get misgendered. When my mom is happy with me, I get gendered appropriately. So there's something we have to own about how that happens. So I would say no. I think if you cannot ask people, then maybe using they until you ask could be okay, but a lot of people really want to be referred to by the correct pronouns. Also, sometimes people, if they don't understand that what we're indicating is a pronoun, they can be confused about how many patients we're talking about. This is, and so so I think it would be more appropriate, if it was my paperwork, it would say, there would be a place that said the pronouns, and it would say, John, they, them, and I would indicate that I'm referring to their pronouns and say they were issued this material, they are to come for follow-up on this day. So I think it is different. I have a different take than that student in terms of affirming what the person has let us know that they want, but then also not being a jerk about it if what they want changes.
Right off the start of our webinar, you talked about the lack of intergenerational supports that people from LGBT have, that they tend to have a peer group that is the same generation as they are. And I was wondering if you could talk any more or any more insight into some of the unique challenges that older adults who are part of the LGBT may face, especially if they start to go into care or like into a lodge-type care environment or a long-term care type environment.
Absolutely. So, it can be terrifying. It can be terrifying for anybody to lose some of their independence or move into congregate housing. But particularly for LGBTQ people, there can be a real fear that they might be entering a space where they might experience homophobia or transphobia from other peers, and that the staff may or may not be in any position to support them. And so often people will tell me, I actually had somebody tell me recently, we had our first gay. And it was a facility that had existed for 40 years, not a new facility. It was a lodge. And I thought, you're most assuredly, like if 1 in 25 Canadians is willing to tell the federal government when the census comes that they are LGBTQ, certainly this lodge has had other people before. And I said, okay, cool. So there can be some real fear, and particularly there can be fear about the violation of confidence. There can be fear if you need to have someone help you with your bathing or your changing, that private information about your body is going to be revealed. So I think that if we have someone coming into care, we have to have a plan as a staff for how we're going to protect the person's confidentiality. There need to be serious consequences for breaking the confidentiality of clients, because there can be serious safety concerns that can arise for those clients. So also in those facilities, as a facility, what we can think about is how can we do that same scan of our space? So how can we think about what's in our library? What do we show on movie night? My granddad lived in a seniors building. I come from a non-Christian family, and he was like, Chris, could you believe there were this many movies about the Pope and the Vatican the Vatican and Christianity. Every movie night, it seemed like, was a movie about Christianity. So like, think about, what are you showing? What's gendered in the activities? Like, there's all these different ways. So those are some things that those facilities can think about.
I have a question from Krista, another Krista, different Krista, who wants to know, is it
Perfect.
appropriate to add pronouns and name used on intake paper, or is that something that's better or more affirming to verbally ask when you're doing your
I would do both. So I think if it's on intake paperwork and if the person leaves it blank, which some people will, then you can do a follow-up question in person. If they might leave it blank because they're worried about what the consequences will be of answering that information. So I have it. I do both. But I think if people leave it blank, then you can have a follow-up question about that. Also, if it's likely that another person completes the paperwork for the individual, it would be worth having that conversation in both cases, so that you're not making sure that, like, their son didn't fill it out the way the son does it, but the parent actually uses a different pronoun. Also, if I'm interacting with a family or with another caregiver, I always correct what the person has told me they want. So I have a practice, if I'm doing a case conference and the person misgenders, I will just, it sounds probably like a form of Tourette's, where I'm constantly saying she, the patient said she, I'll repeat the name, Sarah, and so just making sure that we're always affirming our patient and what they have asked us for.
Great point, too. I have a question for you. You've talked a lot about pronouns, less about dead naming or the concept of dead naming. And I'm wondering if you can comment, or you might have said it and I just missed it, but can you comment at all about that issue, what it means, and the harms or the challenges? You talked about the challenges of changing name, but the harms and challenges or the problems if you unintentionally.
A number of friends and clients have told me that they have expected, when they've had a medical emergency, even though they have done everything they could to have their current legal name used in health systems, at the moment when they're afraid that they're dying, they know they're going to be in the ER where they're going to be called the wrong name. There is something Murphy's Law about that. I had two people in the same month tell me that story, and I had this deja vu moment. They both thought they were having a heart attack, and they were in ER, and they were called by the name that they have not had on their paperwork for years. So it is inappropriate to use a name. When somebody has let us know the correct name to call them, it's inappropriate to use a former name, or even if sometimes if it's the legal name, we try not to use that name. I try not to know the name personally. I don't ever want to get confused about what name somebody wants to be called. I'd prefer not to know. And so there can be it can be destabilizing. It can be a safety concern when we think about the case example. It could lead to harassment. So I think that can be it's something to be taken really seriously. One other piece that's related to that is sometimes when somebody is misgendered in a care situation, they might have a reaction that feels out of scope to you. So you might feel like, oh, I just made a little mistake. What's the big deal? Why this big reaction? They're very dramatic. You might have a reaction like that. And so it's very important to know that if you misgendered somebody once, you may be the 9th person who misgendered them that day. And you might be the first person who did it by accident. It might be that all the other people did it just to be a dick. Like, if they did it to make a point. They did it to make the person uncomfortable, to make them feel unwelcome. And so I've really learned that sometimes people have a big reaction to me because I'm the first safe person to be mad at that day. They were in danger of getting kicked off the bus if they said something to the bus driver. They were in danger of not getting their sandwich if they said something at Subway. They're in danger of getting detention if they said something to their teacher. But me, I have a safe therapeutic relationship with them. They're allowed to be mad at me. And so I think if somebody has a bigger reaction than you're expecting, try not to personalize it and know that you did make a mistake and the person is allowed to have their reaction. And my follow-up question when that happens would be, can you tell me what happened? Like, how was your day? What's happening for you in your life? Because it sounds like something's really hard. So I would use that as a chance to deepen the therapeutic relationship rather than getting defensive about it if I could control that.
I have another follow-up question around pronouns for you, and this one comes from Cheryl. It says, and it may be all the same practice, but is there a best practice or the best way to go about determining pronouns if you're talking to someone on the phone? Because, of course, you don't have that visual signal.
Yeah.
And voices can be different than how someone may wish to present.
So on the phone, we're speaking to somebody directly, so we're not referring to them in the third person. So that saves us a little bit from confusion. If we have the paperwork done properly, then that'll really help us because we'll know who we're asking for. So if I'm phoning and somebody else answers, I can say, "Hi, I'm looking for Leanne. Could you get her for me?" The paperwork would help me out. If I didn't know, I would try to avoid using pronouns. "Hi, could you get Leanne for me?" So that would be something that I would do. One thing that sometimes comes up for folks is being forced to prove who they are because somebody else has a reaction to their voice. So this is a thing that happens with banks and credit cards a lot, where folks will say, like, I've been a client of this company for ages. I had a problem with my visa. I called, and they just didn't believe that I was the right person. So that's the thing, is just to let people know. But I think if we have good paperwork that lets us know that what their pronouns are, then that'll help us to follow through. On a phone call, we could also say, "Hi, it's Kristy. I'm calling from the Physiotherapy is Awesome clinic. My pronouns are she, her. Can I confirm who I'm speaking with?" And you can ask about pronouns then.
Thanks for that. I have a question from Joe, and I'm not sure if it's really for you or for me as regulator, putting on my regulator hat and taking off my host hat. I'm going to ask you and see if you have an answer. Joe's wondering, is there a legal reason to ask someone their legal next of kin as who to contact first before partners or chosen family? She says she's asking because it was a recent experience that they had.
So in my opinion, there isn't. I want to know who you actually want me to call. And often people will say, does it have, like, a lot of my clients will say, like, do you need to know how to reach my mom? Because I'd really rather you reach this person. I think the really important thing to find out is who is allowed to have access to this person's information. I'll tell you personally that I have a very dear friend who lives with chronic illness. The rules that this friend has is that their immediate family is not allowed to have information about their medical care, and I am allowed. And so this is a constant thing whenever they've had a hospitalization, because people start to tell their immediate family members things who are not allowed to have that information, and I am the person listed who is allowed to have that information, but I'm not family in air quotes. So I think that this is a really important thing to have clearly documented. But I don't know of any reason why you would need to know why their legal next of kin would need to be their contact. So, Leanne, do you have any thoughts about that as college?
Honestly, I don't have an answer to that question off the top of my head. I think what you're saying makes good sense to me, Kristy, and I would have to look into it. So, Joe, if that answer that Kristy's provided isn't your need, please get in touch with us at the college and I can do a bit of research on that. But off the top of my head, I can't think of a legal why that would have to contact.
The only thing I can think about is if it's a minor and they need parental consent for treatment, or they have any kind of protection order, but it still shouldn't need to be their emergency contact. Yeah. Thanks for that question, Joe, and all the others.
That's a good point, Kristy. We are over time, and thank you to the audience for all their excellent engagement. Kristy, there's a conversation we had before we came online this morning, and I just think it's such a great point that I would like to end the presentation by asking you to talk a bit about the trends over time for the trans community in particular. And
so sometimes people have questions about prevalence. What is the prevalence of people being LGBTQ, being gay or being transgender in particular? And I think we can't know what the prevalence is until we know what it is to live with no stigma and no discrimination. And a really good analogy, if you Google what was the rate of left-handedness by year, you will see a chart that says that the rate of left-handedness for people born in 1900 was 4%, and for the last 40 years, the rate of left-handedness has been about 12%. I am left-handed, as was my father and my maternal grandfather. My father had his hand tied to his chair to force him to learn to write with his right hand, and my grandfather was beaten for using his left hand in school. So I don't know how many left-handed kids there were because nobody was allowed to be. And so this is a really helpful analogy for me. When we think about prevalence and there being more people self-identifying, to me that's a very positive thing because it means we have more people who are able to voice the truth that they know about themselves with less fear of violence. But there are forces out there that see that with suspicion or with mistrust. My experience is it's my job to affirm my clients and to help them to live their lives, to help them to take up space in the world. And so my advice to you as providers would be to listen to what your clients say, to greet them on the level that they ask to be greeted, and to help them to thrive in the body that they are working with and in the life that they are living, rather than trying to disprove them or like dismiss their identities as trans. This has been really great. I really appreciate everybody coming. I really appreciate everybody for asking questions. And thanks to Leanne and Sean for your work in organizing this.
Thank you so much, Kristy. That was an excellent session, and I really appreciate your time this morning. I know our audience did as well. I'll remind everybody that we will have a recording of the session on be up within 2 business days.